I'm back. You know what that means, don't it? We about at the end. No, thank you all again. Thank you for, this has been a wonderful day, a lot of information. Now, we saved the best for last because I am the one up here on the podium. That's how I roll. See? Check is in the mail. All right, so good afternoon and welcome to our policy panel. Let me give you a couple of numbers right quick. Number one, more than 20 states have passed laws requiring insurance companies to cover biomarker testing for cancer patients. But many states, patients on Medicaid still are being told no. Amen? All right. Number two, the 340B program, drug discount program, has grown from $9 billion in 2014 to over $81 billion by 2024. That's a massive amount of dollars flowing through hospitals that serve patients like you. Now, none of this is abstract. It lands on real people in waiting rooms, in treatment chairs, in conversations with insurance companies that tell you no. So let me introduce our moderators today for this wonderful panel of individuals up here that are going to take you through two distinct topics around policy, one biomarker testing, the other one around 340B. All of these have everything to do with access. And for our organization, we really want to make sure that this community understands that it has access in places and understand what that access means. And when access is not given, who you need to yell at. So, all right, without further ado, our two moderators are going to be, one is going to moderate our biomarker testing panel is going to be Eric Weinzettel. He's the Director of Advocacy for the American Lung Association in Louisiana. Ladies and gentlemen, Eric Weinzettel. And for the 340B section, we're going to have Mr. Thomas Johnson. He's the Executive Director of the ASAP 340B nonprofit organization out of Washington, D.C. Ladies and gentlemen, Mr. Thomas Johnson. Now, behind me are some wonderful people who I call my friends. Now, they may not all agree. That was funny. They might not all agree, but they all do agree on the fact that our patients need to get access to the things that are made available to them. They also agree that that these communities really need to be protected and served. And as long as we got a place where we can start, where we can agree, we can have any kind of conversation we want to. All right, so let me see. Because I'm getting ready to get off track here. So let me follow the script they gave me. All right, so sitting behind me from the great state of Georgia, ladies and gentlemen, Mr. Billy Mitchell. He was elected as state representative, currently serves in the Georgia House of Representatives, former caucus chairman, minority caucus chairman in the state of Georgia. He was elected with me when I was elected in the state of Georgia, and then I got out after he got in because I said, I cannot stand this. No. No, but ladies and gentlemen, Billy Mitchell has been a great legislator. Let's give him a hand for serving on this panel. I want to introduce from the great state of Texas, Representative Retta Bowers. Now, Retta has spent an enormous amount of time in the Texas legislature. Somebody back there got the longhorns up. We don't do that in Georgia. We whoop up on longhorn. We eat steak in Georgia. How about that? Retta Bowers from the great state of Texas, serving the Texas legislature, really is one of the leaders specifically on a lot of the health issues in the Texas legislature. We are proud to have her serve as part of this panel. Ladies and gentlemen, give her a hand. Now, I just got back from Denver where Delegate Martinez and I served on the panel, and they gave me a 6-page CV to introduce him. I said, I'm not reading all of that. Delegate Martinez went to college. He did some stuff, got elected. Now he's doing a great job in the great state of Maryland. Ladies and gentlemen, put your hands together for Delegate Martinez. And last but not least, I really want to talk about this guy. He's the alligator farmer. Josh Spagnola, representing AstraZeneca, great friend to the patient population, great guy, really has been working with AstraZeneca for a while. He looks old. He's about 27 years old. So I just want to know that. He's lived a hard life. Let me just say that. But Josh is a great guy. AstraZeneca is one of our sponsors for this event. And I just want to say thank AstraZeneca, actually for all of our sponsors that made this possible. But he is going to give the industry's perspective around the 340B and biomarker testing. So let's give him a hand for who he is and what his company has done for this great organization. Ladies and gentlemen, I know y'all tired of looking at me, so I'm going to turn this over to Mr. Eric Ronzetto, and he's going to talk about biomarker testing. Put your hands together. Come on up here, Eric. Now, you can moderate from wherever you want to, and let me just, because I'm going off stage.
I'll sit here so I can get a good view of all these lovely people.
Okay.
Thank you, Howard. Thank you, everybody, for joining us. I'm Eric Weinzettel. I'm the Director of Advocacy for the American Lung Association. This is way off topic already, and I think they're going to regret asking me to moderate, but since he brought up alligators, I think it's pertinent to our discussion. If you guys have seen that great video of a woman from Louisiana, the best way to tell if there's alligators in the water, have you guys seen it? If the water's wet, there's alligators in it. So I'm going to go ahead and get started with our biomarker discussion. And I'm going to set the scene for what's happening in the country right now on biomarker testing. So more than 20 states have passed laws saying that insurance companies must cover this test when a doctor orders it. Tennessee just sent a new bill to the governor this week. Mississippi signed one into law last month, and these are real wins, but there's a catch, and it matters enormously to the patients in this room. In many states, the law only covers patients with private insurance, and if you're on Medicaid, the government insurance program for the people with lower incomes, you may still be denied. And in New York right now, there's an active budget fight where the governor has proposed making it even harder for Medicaid patients to get this test covered. The state Senate said no, but it's not resolved. But what this means in plain terms, two patients sitting in the same waiting room with the same lung cancer diagnosis may get very different care, based entirely on what kind of insurance card is in their wallet. So I want to start out with our state legislators because you are the ones who write these laws. To the people in this room who have been through biopsies, scans, and diagnoses that have changed their lives overnight, a biomarker test could tell their doctor which treatment gives them the best chance, but insurance companies can still say no. When you get back to your state house and fight for a law that changes that, what is the argument that actually moves your colleagues, and what pushback do you hear that's the hardest to answer? And I'll start first with Rep. Bowers.
Thank you. Can you all hear me? Good afternoon. And I want to say thank you to all of you that are here at this time and have not gotten taken away by Jazz Fest or the golf tournament or whatever else it is. This is very important conversation. And you're asking, Eric, what will we say to our colleagues and when we're receiving pushback? You know, this is about access and truly fairness when you look at the biomarker testing and what it could mean for life-saving treatment. It also gives them on the spot the treatment that they need right away, like cuts away from delays. That really do. Time really matters for the patients that are in this room. And we have to know that it truly is about moms, dads, and families, and certainly those caregivers as well.
Thank you. Brett Mitchell?
You know, that's a tough question. Tough question indeed when you talk about Georgia. You know, the moniker of our state is we're the #1 place to do business. And before I go on any further, let me just say that I'm a capitalist at heart. I have no problems with corporations making as much money as they possibly can, certainly as long as they treat the environment and the employees fairly. It's this part of the circle of life. They do well, they expand, they hire more people, pay more taxes so that we can have more services. So I wanted to get that out. However, when we talk about, you know, biomarketing testing, and Howard, this is no assault on your profession, accountants, I will tell you that, and this is Billy Mitchell talking, that I believed it used to be a time when physicians would make decisions as to what kind of treatment that you receive. I believe now it's more accountants who do cost-benefit analysis as to what kind of treatment that you should receive. I want to publicly thank folks like AstraZeneca and Amgen and others who are conscientious corporate citizens. But to specifically answer your question, I have to say we have to find a business solution as to why we should make certain that these kind of services are available to those who can't afford it.
Thank you. Delegate Martinez.
Absolutely. So the question that was asked is, what will we say to our colleagues? I would say thank you, because in 2023, we passed comprehensive coverage in Maryland for biomarker testing for both Medicaid as well as private insurers. It was House Bill 1227. And the reason we did it is because with anything that we do in the state of Maryland when it regards to health, we try to make sure that there's equity in all policy. A disease doesn't ask you for your tax returns before it impacts your life, and we want to make sure that there is coverage for all Marylanders in all facets of life, because we understand the real implications of lack of coverage. And so one of the things that we did in 2025 was to take it a step further and then protect people's information once you've gone through the testing, to ensure that the insurance companies weren't using those biometric testing results to negatively impact you down the line when you're trying to seek care. This includes comprehensive coverage for not only just the diagnosis, but for ongoing treatment, as well as trying to figure out if there's other things, other elements that you are impacted by because of, maybe it's hereditary, maybe it's something that you know grandma had or auntie had or things of that nature. We try to be as comprehensive as possible when we look at solutions for our population in Maryland. And so the answer would be thank you.
You know, if I may, I tell you, I get always so motivated when I hear Delegate Martinez talk about the legislation that they are able to get through in Maryland. It is just always amazing. I, sometimes wonder, man, are we in the
Look,
same
this is not a political event, but if you elect more Democrats, you'll get better policy.
So I am grateful, and one day we're going to get there. We're going to get there.
But until we get there, it is important to recognize the reality of the political landscape that we live in, and that a fight for biomarker coverage is different state to state, and the way you have to approach it and the way you may have to frame it is different depending on what colleague you're speaking to, what committee you're speaking in. So definitely appreciate just how tough this challenge can be, and for those who've had success, we are jealous, and we appreciate the fight that you've had. Next question, or actually a follow-up. So some lawmakers argue that requiring insurance to cover more things drives up premiums for everyone. How do you respond to a colleague who says, I care about cancer patients, but I also have to think about the family that can barely afford their monthly premium as it is? And I'll start with you, Rep. Bowers.
Thank you. Yeah, I mean, again, it definitely has to do with, you want to consider those that can't afford it. In Texas, there's so many uninsured patients out there. And we try our best to have some healthcare wins. We have not had full Medicaid expansion. We've left the money on the table. But by and far, we try to make sure that we are making sure that patients, no matter where they live, have access to quality health care.
And if you're discussing this bill with a colleague who is more concerned with the budget than with health, is it more about trying to frame it in such a way that they can then, make sense in a fiscal way, or is it just hammering home the health and humanity of it until hopefully they see sense?
So not making sense fiscally can really tank and sink a bill, but we have to make our colleagues understand that this is about saving lives and effective treatment right off the bat, and not by trial and error, is only going to save a life and make it better for the system when it comes to the budget. So,
thank you. Rep Mitchell.
You must be hearing the detractors in Georgia because that's exactly what they say. And I will tell you this, I'm the senior member on our health committee as well as on the appropriations committee, and I will tell you that the state of Georgia will literally give you their checkbook if you wish to bring business into the state. And as I said, where your treasure is, there's where your heart will be also. And that certainly is Georgia. This is, if I go too long, give me this sign here. I tell you, this is something that I contemplate quite a bit. As a matter of fact, I will tell you, and Martin Luther King Jr. himself said, of all the forms of inequality, injustice in health care is the most shocking and inhumane. And I will tell you that if you are poor in this country, the level of health care that you receive is dramatically different to those who have resources. I think my colleagues in the legislature will tell you there are days when you can't walk a straight line in our capitals without walking into some corporate lobbyist. It's easy to be able to say, who is protecting the average, everyday citizen who has no advocate for them? And that, by and large, should be us. That's why biomarketing and the 340B program in and of itself was created to care for those who cannot care for themselves. If I may, I will say, I believe, and I'm a spiritual person, and I believe one day the Creator is going to come to those of us who've been placed into leadership, and he's going to say, when I was hungry, oh, you tried to cut SNAP benefits. When I was thirsty, you poisoned the water in Flint, Michigan, and other places. When I was a stranger, you built a wall, tried to build a wall at the border, separate kids from their parents, sometime never reuniting them. When I was jailed because of your prison industrial complex. When I was sick, you tried to cut affordable health care. And politicians will say, dear Lord, when did we ever do that to you? Now, you Bible readers know he'll simply reply, inasmuch as you've done it unto the least of these, you've also done it unto me. So I think we have an obligation to do what we can for those who would ordinarily not have the opportunity to gain those kinds of access.
Thank you. Delegate Martinez.
So to answer this question, I believe two things. One, budgets are moral documents. And two, priorities get paid for. And I think if we truly want to have the outcomes, particularly the health outcomes that we know our communities can have, we need to put our money where our mouth is and make sure that we're funding a lot of these programs and just policies of coverage, because the insurance companies are never going to say yes to covering more. Their job is to spend as little money as possible and collect as much as they can. And that's a battle that we often have. I serve on the health committee in Annapolis. That is a battle we often have with our fiscal notes is they tell us how much the cost is to the state, but not necessarily how much the cost savings are going to be. Particularly this year, for example, I had a bill that expanded our Medicaid plan to include a plan amendment on obesity coverage. Right now, the state of Maryland is prohibited through our Medicaid program to cover obesity unless you have more disease. So unless you have obesity and diabetes, obesity and high blood pressure, obesity and asthma, you can't get a whole host of drugs that could help you with the first issue that you had, which is obesity. And with 43% of Marylanders, adults, having obesity, it was something that I think, have a responsibility to tackle. One of the things that we didn't talk about was the cost savings of if we tackled the obesity and then we're able to not have people on lifelong diabetes drugs. What would that look like for our Medicaid program? When we look at like our pharmaceutical affordability board that we have, the first 4 drugs that they're looking at capping the cost on are all diabetes related. And so when we look at this healthcare kind of continuum, we need to be looking at it holistically, not only on what we spend as states, because all states have to balance their budgets. None of us can leave our state houses with things in the negative, but we also need to look at what are the cost savings going to be in totality when we think about these policies.
Very good point. And I'm going to stick on you for this next question because I think with your passage of the comprehensive coverage of biomarkers, that's something you might be facing in your own state. So what's happening in New York is that the governor proposed making it harder for Medicaid patients to get biomarker testing covered, essentially creating a system where patients with private insurance get the full benefit of this test, but patients on Medicaid get a limited version. The state Senate pushed back, but the fight is not over. Do you think this is acceptable, that your zip code or your income level should determine whether you get the test that could identify the best treatment for your lung cancer?
No. I don't think that's acceptable. I also don't serve in the state of New York, and so that's not a battle that we have facing us in Maryland. But I will say, in anyone looking at cost containment measures, you ultimately are putting a cost on human life, right? What is it going to cost the state to keep this person alive is a question that us as legislators have to ask ourselves. And so to my colleagues in New York that are facing this problem, they need to come up with an answer for that.
Thank you. Rep. Mitchell, do you have a comment?
What he said.
Trying to give you all some softballs.
Yeah, the reality is we certainly need, Georgia is one of the small minority of states that has not expanded Medicaid, which means the taxes that would have gone in the federal government even has billions of dollars in the reserve for us to help expand Medicaid, but the leadership of our state, I should say, has decided that that is not something that they wish to do strictly for political reasons. And one day, when Stan Watson gets to be governor, we're going to correct that so that we can do at least some of the things that Maryland is doing.
And Rep. Bowers.
There you go. I would just say that I agree. Not at all. Where you live, how much you earn, and the card you carry in your wallet should not determine the care that you receive and how much care you receive. And I think I wanted to add to something that Delegate Martinez said about just the fact that when you're in there, it is a dollar amount that you're thinking about, and you shouldn't have to think about negotiating with an insurance company and how much you can get them in your favor to go ahead and cover. The coverage that these patients need to receive is necessary to be received when needed. And if the doctor's ordering that, then you want your insurance to work for you at the time of need. So I just would say that not at all. It's truly wrong, and that's why earlier on I brought up the word fairness.
And just to add to that, when I think about any of the cost containment measures that are placed in trying to differentiate how we stabilize our healthcare markets, I also see them as hurdles or barriers to care, because whether it's a $50 test or a $2,500 biomarker test, that is a decision that now this person who didn't necessarily know they needed to make is now making a decision about whether or not they're paying for Little League, whether or not they're putting a certain type of food on the table, whether they're buying another car, or whether they're going to pay for their other insurance. Just the cost of living alone is just very expensive. I call it the management of humanness, like being a person. Just the management of that is extremely expensive on its own. To have an illness is just an added factor, and as people, we're going to get sick. That's just an unfortunate reality of being a person. And because of that, I think we need national solutions around our healthcare. We shouldn't have this 50-state kind of hosh-posh patchwork of policy, because that is why we're in the position that we're in, where my friends in Georgia might not get what my friends in Texas or in Maryland can receive.
right? And I think we're kind of seeing it now, right? Is that we are asking this question on the idea of private insurance versus Medicaid, but we're seeing now not all Medicaid is created equal, and so it's an extremely complex thing that we're all trying to navigate. And moving on to biomarker, I want to turn over to our pharmaceutical industry panelists now. The companies represented here today make many of the targeted therapies that biomarker testing is designed to identify. In some cases, a biomarker test is actually required before a patient can even start a particular drug. So the drug companies and the testing question are deeply connected. And I want to ask both the commitment to patients and business reality, because the people in this room deserve honesty about both. So your companies publicly support laws that require insurance to cover biomarker testing, and that's a good thing. But let's be honest with the audience, your companies will also profit when patients are tested, because testing can lead to more prescriptions of your drugs. If a patient in this room were to reasonably ask, are you fighting for my access to this test because you care about me or because it's good for business, how would you answer that question?
Yeah, well, appreciate it. And I first want to start by thanking HEAL for bringing everybody here. It's sometimes we get in rooms and we talk about issues in echo chambers with people that know the same issue. What I like about this conference is it's policymakers, faith leaders, health experts, patients, caregivers, and survivors, and we can really have a conversation. Before I answer your question, I think it's been alluded to a little bit up here, but on biomarker testing, the states represented here, Maryland, Georgia, and Texas, and the 3 legislators on this panel have all voted for and passed comprehensive biomarker testing coverage. So I just want to be very clear and let the room know, and we all know the importance of biomarker testing, but I've worked on this legislation in Georgia and Texas specifically, and the opposition from the insurers was fierce. So it's not anything that we could take for granted. It was a big vote, and you all put patients first, and I think that's a goal we share. You know, to your question about biomarker testing, you know, I think the whole reason that pharmaceutical companies exist is to engage in scientific discovery and provide medicines to help patients out. If we have those discoveries and patients can't get the treatments or the medications, there's no point in the first part. So with biomarker testing, with the innovations we've talked about at this conference, we're getting away from broad-based chemotherapy with all of the horrible side effects, and we're really developing precision-targeted medicines. As such, you don't want to just give somebody who has a diagnosis random medications, and with the advances in precision medicine, we're seeing if you have a biomarker test, we now have the technology where we can see, based on the genetic makeup of the individual, we can target you to a medicine that will have a better chance at working. So, you know, do pharmaceutical companies make money from selling medications? Absolutely. We then turn that into research and development to continue the innovation. And, you know, I think for us, the business case of biomarker testing is we know there's treatments out there, and if somebody's having to wait 3, 4, 5 weeks to find out if it's covered from the insurance company, even if it is covered, now we have to get the test prior authorized. I'm not talking about the medication. You're now adding in 6, 7 weeks. For us, biomarker testing, it's something that will connect people to care quicker. We will save so much time, and at the end of the day, it comes down to a human thing. We want to help people out if the treatments are available. There's a business case to it too. I mean, the cost of biomarker testing, relatively speaking, is very little, and the offsets of, you know, reduced emissions, inpatient stays for side effects from broad-based chemo. I mean, it's a win-win financially and for the patient, and most importantly for the patient.
Agree, and that's what could feel so frustrating at times, is that we see something that has such a great benefit and the relative cost is considered little, but the going through the process of it, the time spent, the administrative burden, and sometimes you will be denied your biomarker testing. So I'm wondering, for your company, if you have a patient whose insurance has denied their biomarker testing, what can they actually do? Do you have any programs that your company has in place right now to help that specific person get tested?
So I think we've talked a little bit about health insurance benefit design. It's very complex. It depends on where you live, what type of coverage you have. The restrictions to get approved are pretty pretty intense sometimes. There's a lot of cost sharing if you have private insurance, and so a lot of manufacturers, AstraZeneca including, have programs if you are uninsured or even if you are insured and you need help paying for your medication. There are programs that you can go through manufacturers. I would say it shouldn't have to be that way. We should really have health insurance benefit designs that are affordable and are easy for patients to access. But yes, I mean, we will do whatever we can to try to get people that access, because again, if you have a high deductible health plan and your out of pocket is so much, we don't want that to be a barrier for you getting connected to care.
But we appreciate that. And you made a very good point about prior authorization and the administrative delays there. In lung cancer, where time genuinely matters, those delays can cost weeks. Illinois just passed a law saying insurance companies must respond to urgent requests within 24 hours. From where you sit, working with hospitals and insurance companies every day, is this actually possible? And if the insurance companies are not meeting reasonable timelines, what can be done about it?
Yeah, absolutely. I mean, I think prior authorization timeframes, especially in an age of AI and increased technology, if we use it right, can help get the prior authorizations approved quicker. We've seen certain instances where it's been the opposite, but I think if you look at states, I know Texas has passed laws, Georgia has laws in the book that require fairly tight timeframes for prior authorization turnarounds. With how sophisticated insurers are, there's no reason why PAs can't be turned around quickly. And so I know in Georgia and Texas, it's something around 72 hours for a non-emergent prior authorization and 24 for an emergent. So absolutely, there is no reason why there should be delays. There are instances where there's some legitimate clinical questions, so we don't want to wait 2 weeks to say, oh, there's some more questions, we need to dig into this. 72 hours, and many insurers do under that 72 hours. There's no reason why it shouldn't be done, and that's absolutely something that's a big priority for us.
Great. All right, I'm going to open this up to the whole panel, and I'm going to ask for straight answers, just your first reactions. Going to give everybody about 45 seconds to a minute. So there's a patient in this room or someone at home who has Medicaid, was diagnosed with lung cancer, and is trying to get a biomarker test covered. Their doctor says they need it. Their insurance has said no or not yet. What is actually standing in the way, and what is the single most important thing that could change in the next year to fix it? And I'll start with you, Rep. Harris.
Well, thank you, and I wanted to, 45 seconds. So I wanted to say, though, on that day when we take that vote, that's when the blue coats come in the gallery, and they call it the blue coats because they're all up there watching whichever way you're going to vote. But in 45 seconds, I mean, it's just that this is when you know it's people over politics. And you really have to know that it is life-saving. And you can't put a cost on someone's life. So that's all I have.
Josh?
Yeah, I mean, we've talked about it a little bit already. I think we need to get back to where the clinicians and patients and care teams not only make recommendations, but make decisions, and those decisions are honored. So I think that's been one of the major pushes behind the biomarker testing legislation. I know Representative Mitchell worked on a resolution that passed before the bill was even filed in Georgia, because we knew there was going to be a huge fight from the insurers. So to answer your question in short order, absolutely. We need to get as many barriers out of the way between a patient and their physician in treatment.
Right, Mitchell?
Yes, we must certainly work to discourage those kind of barriers. We've had the scenarios like that where there's an appeal process, but it certainly takes longer than the 72 hours trying to get that done. And since you mentioned that resolution was done for the National Black Caucus of State Legislators, I see the CEO is in the audience, Lakimba Desideer. That was unanimously passed. For those of you who don't know, NBCSL is the organization of black state legislators in this country. Over 40-some-odd% of current congressional members of the Congressional Black Caucus are former members of NBCSL. First met Barack Obama at a NBCSL annual conference in Chicago. I said that to say I agree with Delegate Martinez. We need a national solution to this issue because that is not, the scenario that you painted is not uncommon. It has resulted in appeals and suits and the like. We would try to apply some political pressure in the scenario that you painted, but that should not ever be the case. I'm anxious to see how Maryland would handle this case with the scenarios that they have going on there.
Yeah, so if someone is from Maryland and they're having an issue, right, I would first ask them to email my office so I can quickly send an email out to our Medicaid department within the Department of Health, because this would be a violation of the law. We have coverage already. But what I think about more so, since I have some more seconds, when it comes to prior authorization and really any of the cost containments, we got to get the insurance companies out of the operating room, out of the doctor's office, and let our physicians actually practice medicine. There's a lot of administrative procedures that go into the cost containment around care instead of just providing the best pathway that our physicians think they should. And I think a physician should be the head of the care team and be providing those types of care for, our neighbors.
Thank you. And a question to the whole panel. We have a room full of people with amazing stories. And one of the things that I often say and have been told is that you can have a legislator who can quibble with you over facts and figures, but they can never question you or they can never deny your story. So with this room of potential advocates, what are the next steps they can take? We have these goals of getting insurance out of the operating room, to removing barriers, to expanding Medicaid, all of these things that we want to do and that we should be able to do. How can we best harness their voice to actually make it a reality?
I think it's about empowering patients and caregivers to tell your story, because you're your own best advocate. And come into those state capitals. If you can make the time or have the time, please come. Reach out to your legislators. And it's places like this where HEAL Collaborative brings us, as Josh said, all together in one space where we can all come to the table and share the knowledge that we do have, whether it is a patient who has walked their own journey, the physician who is caring for that patient, or the caregiver. And certainly the legislators here today, we do have to stand up for our constituents.
Yeah, I mean, this one's easy to me. Representative Mitchell talked about walking through the hallway in the Capitol in Georgia and tripping into corporate lobbyists. I spend my time in capitals, and I put the best case forward for patients, but at the end of the day, your story is what matters. And I think we see sometimes patients say, well, I don't know how the system works. I don't think I can make a change. Don't kid yourself on that. The bill passed in Florida, and it was not because I was talking to legislators in Florida. I know HEAL worked with over 30 patient organizations and brought them to the table for the patient discussion in the biomarker testing bill in Florida. So your voice matters, your experience matters, and your voice really carries the day. So, show up, write an email, testify. You don't need to be a healthcare executive, a healthcare expert. Your story is what matters and really helps the legislators here understand the human impact of these proposals.
I'd like to join that chorus. I will tell you, the electeds can tell you every now and then we hear people say, how come that community over there seems to be better served than this community over here? And I can give you all kinds of sociological theories as to why that is, but the main reason that is, the community that is well served, they are engaged, they are informed, and they advocate for their best interests. And the community that is underserved, they are uninformed, unengaged, and they do not advocate for their best interest. If we could miraculously pick up everyone from the well-served area and place them in the underserved area, and put everyone in the underserved area and put them in the well-served area, guess what would happen virtually overnight? The services would flip simply because the people who are well-served are engaged and informed, and they advocate for their best interests. Now, in community forums and the like, I used to tell people, how many of you have ever said, I only see that politician during election time? Now, don't raise your hand if you've said that. Don't do anything because it became embarrassing. Well-served people don't say that. Well-served people see a problem, and they say, let me call the elected official who has responsibility for this to get something done. underserved people see a problem and they say, look at this. I wonder when someone is going to do something about that. And we have to get folks involved and being engaged in making certain that their issues are addressed. You know, power doesn't come from the Capitol, it comes to the Capitol, and your engagement is what makes the difference.
So I'm going to just join in as well and say, you know, storytelling is the best tool that you have in your advocacy toolkit. That was already mentioned, no one can tell you or refute you your story. And so being extremely annoying, right? Going to the offices, being consistent, going to all of the meetings, talking to all the members on the committee of jurisdiction, being a presence really does matter. And ensuring that you're always constantly just telling your story, because at the end of the day, the squeaky wheel gets the oil. And you have to do that with us. You know, my committee alone has over 500 plus bills. We're spending 7+ hours a day in committee listening to testimony for 90 days. You have a compelling story, you coming in with a lot of energy, you putting your best foot forward is going to make a memorable impact on the legislators, and it ultimately is how bills get passed.
Thank you, panelists. We're not going to leave you just yet. We're going to swap over to Mr. Thomas Johnson, who's going to pivot to 340B, but thank you for all your questions about biomarker.
Thank you. And I spoke with this group last year about 340B reform efforts. I want to talk a little bit about what's developed since then and some new things that are taking place, and talk about our coalition as well. I don't think it's working. Oh, there we go, okay. So last year we had 35 members of our coalition seeking reforms to the 340B program. We now have 47 members. Some of our new members include the NAACP, the Black Legislative Leaders Network, and we continue to grow as a coalition seeking reforms to this program. We've come together because we have concerns about what's happened to this program that we actually support. The program has been around for 30 years. Community health centers, other safety net providers are very dependent upon this program. It helps them serve their communities, but some entities participating in this program or abusing the program, they're taking advantage of the lack of clarity at the expense of patients that they serve. The way the system is supposed to work is like this. The manufacturer has an agreement with a covered entity, that's a hospital or a clinic or other type of entity as described in the statute. They receive a discount for certain outpatient drug purchases. Discount now is about 59% of the cost of the drug. They're able to keep the difference. What's happening now, because of the lack of clarity in the statute, is that PBMs and other groups are getting involved in setting the price for these drugs. In some cases, they are now billing Medicaid, Medicare, and other entities 5 times the cost of what they acquired the drug for, and keeping that as a profit. Because of the lack of clarity in the statute, they are able to do that according to the law. The program is not working as intended in many cases, especially with regards to some of the practices that hospitals are engaged in. The program overall, as Howard mentioned before, covers $81.4 billion in purchases as of 2024. It's expanded significantly, but there are few transparency and accountability measures in the program, and in fact, certain entities are treated differently with regards to the transparency and accountability than other entities in the program. The program is encouraging hospital consolidation, flowing away from low-income communities as hospitals prioritize patients with higher-paying private insurance. And as I said before, there are others that are profiting greatly from this program. As you can see from the pie chart, 87% of the purchases in this program are by hospital systems,
All of the other covered entities, including community health centers, AIDS clinics, and other types of entities, comprise 13% of the purchases in the program. In terms of cancer care, 340B hospitals tend to use higher cost cancer care drugs, netting larger profit margins. Revenues earned by those hospitals in cancer therapies was over 10 times higher than non-340B hospitals. In North Carolina, 340B hospitals charge some employees more than 5 times their cost for cancer drugs. And in one case in Virginia that we found particularly egregious, a patient was billed $22,000 for a drug that cost the hospital $2,700 under the program. That hospital received reimbursement from Medicaid for $10,000, and then they sent the patient a separate bill for $2,500. Again, we talk about the incentives that are created. The average 340B margin tied to a medical oncologist was far higher than for other providers. Cancer treatments account for 41% of 340B purchases. The average margin per provider was $570,000 versus $64,000 for other providers. 546 340B hospitals added a cancer-focused child site, which is a site that is outside of the actual hospital setting, increasingly in affluent areas over the last decade. Minnesota actually released a report this year which showed that 340B covered entities reported $1.34 billion in net revenue, with the largest hospitals accounting for more than 80% of that total. Half of grantees spent at least 54% of their gross 340B revenue on administrative staffing and other types of costs, not on patient care. The largest revenue-generating drugs were primarily specialty drugs, including drugs often used in cancer care. There's been activity in Washington over the past couple of years. What I will say is that we've endorsed legislation in the past capturing our principles, and there is leadership on both sides of the aisle that is interested in trying to find more transparency with regards to this program. In the meantime, there's a lot of litigation that's taking place, trying to interpret the statute at the federal level and at the local level because of the lack of clarity in the statute. Abbey v. circuits allowing certain state laws to stay in effect regarding contract pharmacy and other issues. There's a rebate model that has been talked about at the federal level that has some opposition, and we're going to see how that develops as an alternative model to the current system. Just 3 instances that I'll point out regarding hospitals turning 340B revenue into profit. The Cleveland Clinic, $1 billion in 340B revenue, none of which was passed entirely to patients. Bon Secours, despite being located in one of Richmond's poorest communities, they used its profits to fund expansion into wealthier areas. Sun River Health generated over $100 million, primarily from HIV/AIDS, hepatitis C medications. 3 of its 30 clinics produce over 50% of the program's total 340B revenue. What we are really calling for is the same type of accountability for hospitals, which use 87% of the dollars in the system, that other entities that are HRSA grantees, like clinics, we're calling for them to have the same accountability. So that means reporting on what they're using the money for and how much money they're getting, and reinvesting that money into patient care. Also developing a sliding fee scale for those who have copays or are unable to pay. We think those are very reasonable demands to make sure that all 340B covered entities are treated the same. Just a chart regarding the fact that 340B hospitals are providing less charity care, even though they're getting these dollars, than nonprofit and for-profit hospitals. And this chart kind of outlines the same thing in terms of the types of charity care that's provided by 340B versus non-340B hospitals. There were 13 groups that are very involved in health equity, wrote a letter to Congress in December of 2024 calling for accountability in the program. Many of these groups were not with us at the time when they wrote this letter, but they are now members of our coalition. So we want to ensure that savings are used to help patients and true safety net providers prevent abuse of the program and verify that the program is actually working. Thank you. There we go. So I want to ask a few questions just kind of to close things out to get your views on what's happening in the program. And Josh, I'm going to start with you. There's been a lot of talk, there's been frankly a lot of litigation and a lot of concern about this contract pharmacy issue. I know when I appeared at this event last year, Delegate Martinez was very vocal about his concerns about some of the practices that he cited that's taking place within the industry. So, you know, I want to just kind of get your thoughts about this issue. You know, it's one that kind of stands out in the debate regarding reform and, you know, just kind of set the record straight about, you know, what's happening with contract pharmacy.
Yeah, I appreciate that. Oh, there it is. All right. Thanks, Thomas. I appreciate that. You know, I think two misnomers that I want to speak to first. One is the idea that manufacturers don't like the 340B program. That's absolutely not true. We're huge supporters of the 340B program. It was designed in 1992 to help fix an issue with the Medicaid program that really hurt community hospitals. So the program was designed to take the rebates and the discounts that Thomas talked about and give the spread to hospitals to help them provide care for uninsured and underinsured individuals in areas of need. There are a lot of hospitals that use the money for that purpose today, and we support that. Thomas also mentioned there's been a lot of growth in the program. We've seen that through contract pharmacies. So a hospital will have their own in-house pharmacy, and then they started using other pharmacies outside their own pharmacy. We've seen that grown to over 200,000 pharmacy arrangements outside the hospital. Now, if the money were to go to the patients to help offset the cost, I think the conversation would be a little bit different. But as Thomas mentioned, a lot of the extra funding is being used for capital expenditures. In many instances, for many hospitals, they have their anchor hospital in an area of high need, and they're taking the revenue and the profits from the 340B program and building clinics and hospitals in affluent areas with high rates of commercial coverage. And we just don't think that's right. So I think there's a push in some states to expand the use of contract pharmacies. And this is one where we've had a lot of discussions with this. Delegate Martinez, Maryland was one that did that. I will say this, I think the Maryland piece also included a provision that has a state board to do a study to look at what's going on in the 340B program. We welcome that study, but we just have a concern over expanding the growth of contract pharmacies. You know, after we limited the number, the program went from 25 billion to 81 billion. I think a large driver of that is the for-profit pharmacies. They have found a way to get into this game, and they get the spread and they keep a lot of the money. So from our perspective, we think that there needs to be some guardrails put in the bill, in the program from Congress. It's a federal program. We think there should be accountability. I think the taxpayers and citizens of this country deserve to know where the money's going and how it's being used to serve the original purposes. And I think that will change the paradigm of the program and fix what we view as broken. So I think the goal of every legislator up here, and there's been 340B bills in every state, is to help get the impact to the patient. I think we do have a little bit of a disagreement on how that's approached in Maryland, but I appreciate the approach that Delegate Martinez has taken in our conversations. And I think this is a time where we work strongly with hospitals, and friends can disagree. So I think that's sort of our perspective on it. I appreciate everything that Delegate Martinez has said. And again, I want to credit him on the bill he did vote on. It's a bill that we have some concerns with. It does have that provision say, hey, State of Maryland, let's look at the program and see what's going on. I think if that report comes out this summer and they take a thorough look, it's going to be telling, similar to the report we've seen in Minnesota.
I think Delegate Martinez was said as many times as 340B in this conversation. Let me be clear. I believe in transparency. I believe within anything, you got to kick the tires from time to time and look at whether or not the impact is actually meeting what the intent was. We know those are two separate metrics that we're always having to circle the block on when it comes to public policy. Show of hands, how many people in here know what a contract pharmacy is? So that's your CVS. That's your Walgreens. That's your local pharmacy that your hospital or the covered entities would have a relationship with because they know that's who services their patients. We can get into a whole nother conversation, and it'll be as long as this day, about PBMs and how pharmacies kind of fund themselves and the insurance companies and everything else. But the reality is, in Maryland, we understood that the CVS that I walk to is the same one my neighbors go to, and that's where we receive our pharmaceuticals. So if we're a recipient of 340B, we should be able to receive our drugs at the most convenient place possible. We passed a bill a few years ago that said, hey, hospitals and manufacturers, if you want us to still perform this program, then you've got to allow individuals to be able to go to these contract pharmacies. And if you manufacturers have any type of change in that contract, then that's a consumer protection violation, and our Attorney General is going to go after you. Well, we haven't even been able to have the bill go into effect because we were immediately sued by the pharmaceutical companies. And so while I appreciate the gentleman's love of the study, we haven't even been able to do that because we still are in litigation. We just had an injunction placed again on the program by the Fourth Circuit, which is the federal court that oversees the state of Maryland. And so we are still very much waiting to see the impacts of our law go into effect. Again, I believe in transparency. Something that was mentioned earlier around administrative cost, right? How many of you guys can understand that with any type of administration of business, there's going to be individuals that have to administer that? The administration cost goes to the growth of and the demands of our healthcare system. If you want better outcomes, you need people to produce those outcomes. That is part of the reason why those costs go there for certain hospitals. Now, the bad actors that they've been able to point out that are investing from historically underinvested communities, taking away those 340B dollars and putting them in minority white communities and wealthy communities, that has to stop. I don't think anyone on this stage believes that is the proper use of those funds. But those are a few bad apples. That's not what the entire program is run through. And so I think as we look at reforms to this, we've got to understand that when we put in cost mandates or cost constraints, when we put in means testing about who is eligible and how much of eligibility they have, a lot of the people in this room are going to be impacted.
So for a, I want to ask the state representatives this question. You kind of see that, and I guess this is kind of pictured this way, there's a battle between very large groups at the federal level, but even, through your states as well, in terms of where this program is going. One thing, though, that I think stands out with those of us who are trying to see some changes to the program is to just have some transparency in reporting. I have found that recently members of Congress on both sides of the aisle agree in principle that there should be some type of transparency. Would each of you commit to the fact that there should be some type of transparency and reporting in the 340B program?
Again, I believe in transparency. I'm not going to commit to a pathway to that at this moment, but if we do have reporting, for example, there will be more administrative cost.
Yeah. Well, I certainly believe that transparency is one of the ways that we can get to the end, the goal of what 340B was supposed to be. I just simply believe that we can't allow large hospitals and large healthcare entities to exploit discounts that were intended for people who could not afford them. I think one of the best ways that we can do that, and I just always find it amazing that we have certain entities who fight transparency when all we're trying to do is to make certain that the program is doing what it intended to do. So I will commit. I think Delegate Martinez raises a very interesting point in how we go about requiring that transparency so that it does not bring about additional costs and additional hoops, so that it makes it even tougher for those who cannot afford it.
And I would say absolutely, I believe transparency has to be a part of this conversation, and to make sure that we're holding the hospitals to true accountability when it comes to where those dollars are spent. And I in Texas serve on Texas Doge, and I asked for that committee for oversight purposes. You know, at the federal level, it's DOGE is the Department of Government Efficiency, but in Texas, it's the delivery of government efficiency. And that committee was formed in the 89th. Will I ask for it again in the 90th? I don't know. But I certainly believe from the work we did during the 89th legislative session that transparency has to be on the table.
Josh, let me ask you this question. We talked earlier about the contract pharmacy issue, and I'm going to use a term kind of pushback, I'm going to say, from the industry in terms of some of the things that some of the companies are bringing up. If there were true transparency in this program, as outlined by the Minnesota report showing the type of data that we're trying to get out of this program, do you think that the pharmaceutical industry would maybe pull back on some of the practices regarding contract pharmacy that they've been engaged in?
Yeah, I think when this was passed in 1992 in Congress, it was aspirational, but there were no requirements. There were no requirements that you take a portion or all of the discount that you get and pass it to the patient. So that's the intended goal, but there's no requirement in law. And so, I think if you have multiple pharmacies and relationships with local patients, and the discounts are being used to go to the patient, and there's some guardrails federally around what the program should be used for to align with the original intent, I think it's a very, very different conversation. Without the guardrails in place, some of the concerns have been about the drug manufacturers that we've limited the number of pharmacies that could be used. We did that in 2020. The program was at $25 billion. We're now at $81.4 billion. So there's been tremendous growth. And I don't think it's, we talk about hospitals a lot, but there are a lot of folks, the PBMs, some pharmacies that are owned by PBMs, that have found ways to generate revenue and exploit the program without giving benefit to the patient. So I think at the federal level where the program sits, it's a federal law, a federal program. If we reform the program and say this is why it was designed, and now we're going to put requirements in law that money's really going to go to help underserved areas and the patients in need and uncompensated care, then the whole dynamic of the program changes. So yeah, absolutely. I think if that program's meant to go towards what it was designed to, absolutely. I mean, right now, the 340B program is the second largest federal drug program behind Medicare Part D. This was a small stopgap program. So once we rein in the abuse, once we look at the actors and we direct the money to where it's supposed to go, the whole conversation is very different.
I want to close with one more question, and this goes to the state representatives. And just maybe, give us an idea of what you think is next with regards to what's going to happen in your state
as it relates to the 340B reform discussion. And Representative Bowers, I'll start with you.
Thank you so much, Thomas. So, you know, looking at Texas, it has to be proper state funding that we see for our hospitals. And these hospitals, I think, as Delegate Martinez alluded to, are closest to these patients. They're in their neighborhoods, and we have to make sure that we're keeping these clinics and hospitals open. So I think that it is going to boil down to the money and what we look at what the state is putting toward this program.
Okay, Mitchell.
I will tell you that we're making small incremental steps in Georgia. I do believe that the day will come when we'll be able to expand Medicaid. And it's interesting to note that the 340B program is even a larger program than Medicaid. And I think that we're going to make those small incremental steps to where we expand Medicaid, where we'll get some kind of transparency to where we would get the program to make certain that it does what it is intended to do, and that is for those who can't afford it otherwise. But, you know, I mentioned during the last segment of the panel, this is one of the reasons why I love the HEAL Collaborative so much, because this information empowers all of you. I hope that you truly will become advocates. I can tell you this, that there is nothing more powerful to an elected official, no check, no whatever, than you coming up to an elected official and saying, my name is Billy Mitchell, I live in such and such a street, which is in your district, I can vote for you, this is an issue that's important to me. There is nothing more powerful than that, and you should know who your elected official is. Now, some of you here, because you're advocates and involved in your community, not only should you know who your elected official is, but they should know who you are. And I would use that power to make certain that these kinds of issues are addressed in the legislatures.
One, I want to say, again, I believe in transparency. How we move forward with this program really matters because there are changes coming to our healthcare systems and the administration of care across the country. The big ugly bill that was passed last summer is going to impact how healthcare is administered in our states. Maryland is a very unique anomaly. We're almost like an island of our own, partly because of how we manage our hospitals. Almost all of our hospitals are nonprofits. We do not allow for-profit hospitals. The second thing is they work on global budgets, meaning that there is a commission, it's called the Hospital Cost Services Review Commission, that then sets the rates for what they are to spend for the entire year. Charity care is already baked into that. Ensuring that these 340B dollars are reinvested is already figured to that. But Maryland is one of 50 in our territories. And so we have to think broadly about this program and how we move forward, because the honesty is that healthcare is going to be more expensive to administer moving forward. And there's going to be real consequences around how we balance our budgets, and oftentimes Black and brown communities are going to be the first to be cut off from any type of services and care. 340B might be that lifeline that provides care for you and your communities. And I'll end with this. I serve on the board of directors for a Ryan White clinic called Us Helping Us. They do HIV and prevention as well as medication. And one of the things that they are working on right now is the fact that people are living longer with HIV. It is 340B that's allowing these individuals to live these long lives, to survive a disease that used to be a death sentence. We've got to really think hard when we hear words like transparency. What is it that we are truly actually trying to do, and who are we unintendedly going to harm in our actions of doing it? I think all of us can have the best intentions, but understanding what that true impact is the hard work that we have to do.
Thank you all. Thank you all for participating in the panel.
Representative Mosby, did you hear what he said? They don't even allow for-profit hospitals in Maryland. What kind of,
Please move to Maryland.
what kind of country is this?
Who's controlling the microphones? Can you cut? Okay. So, well, first of all, I want to thank the moderators and the panelists. Let's give them a hand. These were two tough policy issues that we wanted to bring before you. And this is just a taste. We really could have had this conversation for about 4 hours on these two issues, but we really wanted to give you a taste of that access, healthcare access is important. And and we need to make sure that we are all locked arms to make sure that we take care of something. I want to close with something simple. The people in this room did not come here because they love health policy. They came because someone they love or themselves, a diagnosis changed everything for them. And they are doing what people do when they are fighting for their lives. They are showing up, asking questions, and demanding that the system work the way that it is supposed to. Today we heard about biomarker testing, a test that can tell a doctor exactly how to fight for your specific lung cancer. More than 20 states now require insurance companies to cover it. We also heard about the 340B program, a drug discount program that's supposed to funnel savings back into the care of patients who need it the most. Money that goes into this program has grown enormously. So these are not separate issues. They're the same story. It is your story. Will you get the right test? Will your hospital have the right drugs that you need? Will any of the money saved along the way come back to you in some form of better care? So the panelists who sat on this stage today have real influence over those answers. Hold them to what they've said. For every patient and every caregiver here, your presence in this room is advocacy. Your questions matter. Your stories matter. Keep showing up. Please join me again in thanking our panelists here. I want to thank you for your participation. I'm going to turn this over to Stan, what you say, Dr. Tuckson? Standing between us and the white ribbon thing is Stan Watson. So I'm going to turn this over to Stan to give you some instructions, but I want to thank you all for coming out today.
All right. Let's give Howard a hand. He's done a wonderful job this weekend. All right. We're going to ask the panel to stay for a second. We want to make sure we take a photograph with you before we go. Just a few housekeeping. Thank you for coming today. This ends our day. We only have one agenda for tonight. From 6:30 to 8:30, the White Ribbon Jazz reception and dinner will be held in this room. So come back tonight at 6:30, and we'll see you then. Are there any questions for Howard or for the Hill staff? Not at all? Well, we'll see you at 6:30. Ladies and gentlemen, can you come on? Thank you. Y'all give him another hand, please.